we have the fibula lying superficially, and anteriorly the muscle belly here is extensor digitorum longus, and posteriorly peroneus brevis, with the tendon of peroneus longus lying superficial to it. So if we scan proximally, the fibula dives deep, and the two bellies of these muscles come to lie in close proximity with each other. And at this level, covered by deep fascia, the superficial peroneal nerve lies in the groove between these two muscles. Now, if I just scan distally again, and if we concentrate on this area, you'll see that the nerve is lying deep there and moves to becoming superficial to deep fascia there. Okay, so superficial, deep. And if we scan more proximally, we can follow the nerve up through the leg until it dives deep down here. And there it's lying between the belly of peroneus longus at this level, so it's changed from being tendon to muscle, and this belly here, which is peroneus brevis. Okay. Now, the reason why it's important to trace the nerve right back up is, in some cases, the nerve will branch fairly high up in its course. And again, you usually need something in the region of 2 mils to block that nerve. Providing it doesn't block superficially, I block it after it's becomes superficial to deep fascia, because it's more comfortable for the patient if you don't have to pierce the deep fascial membrane. Moving on to deep peroneal, or deep fibular, as I think it should be known now. This is one of the most distal blocks that we're going to do. So we're actually looking at the anterior surface of the tibia, and you can see the pulsation of the anterior tibial artery. And if we just ease off pressure slightly, I don't think it's going to allow us, you can sometimes see 2 veins associated with it. Now, just lateral, which is this side, we can see a structure which is the deep peroneal nerve. Now, if we travel, just go slightly proximally, it's a little bit hard to see, but the nerve actually rolls up to lie anterior to the artery, and that's its classical description, is that as it travels down through the leg, it lies initially laterally, then moves to be anterior, and then back to being lateral. But just to confuse matters, as with all things in anatomy, it can actually be anywhere, so it can be medial. But the further you get down the leg, the more likely it is that you'll find it on the lateral margin. And occasionally that only happens at pretty much around the level of the ankle joint. So to block this nerve again, I'll come in with an in-plane approach with my needle, and again 1 to 2 mils is usually perfectly adequate. And finally, we'll go on to sural. So if we start by looking in the same place that we did to do the superficial peroneal block, so this is fibular, and instead of moving proximally up the leg, we'll move round posteriorly. So that's tendon of peroneus longus, this is muscle belly of peroneus brevis, and as we move posteriorly, we've now got Achilles tendon. And there's a fascial plane in between the Achilles tendon and the posterior border of peroneus brevis, and as superficial as we can, you can see that there's a venous structure which is short saphenous vein, and at the 5 o'clock position there is the sural nerve. And just to demonstrate that further, what we'll do is we'll scan proximally, and what you'll find is that the sural nerve follows the vessel posteriorly and rolls over the top of the Achilles tendon. So it's lying immediately there. And it can lie anterior or posterior to the artery, or in Sarah's case, a combination of lying initially anterior and then becoming posterior. Now, one thing that's been commented on is that